All right, so thank you everyone so much for joining. We are really happy to have you with us today for our presentation. Hopefully you know by now that this is a presentation offered through the Dementia Friendly Community Coalition of Brown County. We are a group of individuals, community members, and professionals and caregivers who seek to offer a variety of services in Brown County. This is offered by the Education Subcommittee. So we offer education related to dementia that we feel is a need in our community that's not being addressed by another organization or individual. So we sometimes offer updates on research, presentations. We've offered the Steering into the Skid dementia plays. And today's presentation is on intellectual and developmental disabilities and dementia. So we are really excited and honored to be joined by Jody Krainer. Jody is the Dementia Diagnostic Clinic Network Manager for the Wisconsin Alzheimer's Institute. She's a licensed clinical social worker who has a lot of wonderful experience working in behavioral health care and for a community-based nonprofit in Milwaukee, and has now been with the Wisconsin Alzheimer's Institute for several years. So she will be talking about the prevalence of dementia in those who are living with intellectual or developmental disabilities, and some warning signs and strategies to screen for dementia in those individuals. So we want to just take a second to thank the Forget Me Not Fund for their support of the Brown County Dementia Friendly Community Coalition effort. And with that, I will turn it over to Jody for her presentation.
Good afternoon. Thanks for the introduction and the invitation to be here. Got a lot to cover, so let's get started. Easier said than done. Okay. I do not have any financial relationship or commercial interests that I need to disclose. As Kate indicated, this will be the purpose of our conversation today. I tagged the presentation the way I did in terms of the title, as well as I wanted to start off with this slide. In the decades that I've worked in the arena of dementia as a professional, I find that there's a lot of challenges and misunderstandings and myths that go on. And one particular one I wanted to address specifically regarding the developmental disability is some confusion regarding individuals that have a developmental disability that is purely physical in nature. And so I pulled up the definition from the NIH website, which talks about developmental disabilities being a very broad category of lifelong disability, and they can be in the nature of intellectual, physical, or both. And so people that are living purely with a developmental disability that's physical in nature, those individuals will not be as relevant to the conversation today, as those individuals are able to go through standard evaluation protocols if being worked up for a cognitive decline. An example, it was when I was an administrator, I worked with an accountant, a very bright man, a CPA. He actually lived with a developmental disability, but it was all physical in nature. So for him, if he started to experience cognitive changes, he would go through the traditional or standard protocols, and this conversation wouldn't be as relevant for him. And so I guess my point is, if you're working with someone who does have a developmental disability, don't assume that the standard protocols won't work, because if it's only physical in nature, they're fine to go through that. So dementia has become one of the most front and center conversations today. And part of that is that we have this large cohort of individuals going through or entering into the latter part of the lifespan. They're called the baby boomers, or otherwise the silver tsunami that's happening. The baby boomers have been beneficiaries of a longer expectancy than their previous generation. And so today, if you were born and assigned the gender male, you would anticipate you'd be able to live to the age of 76 years. And for a female, anticipate that you'd be able to live to the age of 81. That same life expectancy increase has also been realized for those folks living with an intellectual disability. So an individual born during the 1900s with Down syndrome we would have anticipated they would live till the age of 9. By 1930, that expectation for life would have been up to 19 years. 1983, we see it go to 25. And today, we're anticipating a person born with Down syndrome today would live till the age of 66. So with increased life expectancies, what we find is individuals, as they enter the latter part of the lifespan, they're more at risk for the diseases and conditions that occur later in life. And many of those are actually related to the aging brain. And so we're going to talk a little bit right now about the aging brain. So this diagram, I'm going to walk you through it so it's not too, for those who aren't used to these, or it's not going to be overwhelming. There are 4 basic scenarios that we kind of see occur with someone as they age. Now, on the horizontal line, that is from middle adulthood, not birth, middle adulthood until death. The vertical line is your cognition, or the brain's abilities. And so in middle adult life, as there's one scenario where an individual will have some subtle or age-associated or normal type agings that occur with their brain. But these are cognitive changes that are so subtle that the person naturally adjusts to them and it compensates for them. They may be less efficient at multitasking, slower at some retrieval, but these are changes that are really go unnoted. And so majority of the people will actually go through the middle adulthood through until death with just these age-associated changes. The second scenario that can occur is what we call mild cognitive impairment. This is where a person experiences additional changes. However, when you test them in evaluation, there's some slight red flags that come up, but not significant. And those cognitive changes does not impact the person's ability to function or to live everyday life. The third scenario is what we often hear about is the dementia. This is where someone experiences declines significant enough that when they go through testing, they show up measurable on testing, and those declines are now impacting the person's function or ability to live life. And that is what we call dementia. There's been cognitive declines, they're measurable, and then they are impacting the person's ability to live life or their function. The fourth scenario is when someone has a mild cognitive impairment diagnosis, and for some reason they convert into a dementia. So many people will live with a mild cognitive impairment and go to their deathbed with just that diagnosis. However, there will be folks that will convert. And when I worked in clinic, we would have majority of our patients come back annually for an evaluation. And our goal was always to catch anybody who did convert from this mild cognitive impairment into a dementia, so the appropriate interventions could be put in place to help them out. Now, research has been really different, doing different things besides, they haven't been focusing on looking at pharmacological interventions, in that there's been not a whole lot of success over the last decade, but a lot of energy and effort has been trying to understand what's going on in the brain, particularly with Alzheimer's disease. And so now we have these high-tech scans that can be done. We have the ability to take spinal fluid and understand the components of what should be in it in terms of the protein. And we're on the verge of having blood markers, or where they take blood and they can then analyze the blood and understand what's going on in the brain. Well, what they've discovered is that with Alzheimer's disease, that the 20 years prior to actually showing someone shows symptoms of the disease, the pathology or Alzheimer's disease has set up or begins. And this is really critical in terms of future interventions and potential future preventive markers, but it also is a cue to anybody who's in the part of the lifespan to make sure they're paying attention to taking care of themselves, because we know that this pathology, this disease, actually renders itself long before it shows up in the person's life. So it's very important that we make that distinction. We understand what's coming down the turnpike for the clinical world. So this slide here does a really good visual of the incidence of dementia. Now, the vertical line here is 1,000 people. So as you can see, if there are 1,000 people, someone in the age bracket of 64 to 69, the chances are very slim that that person would have a dementia condition. Maybe like 10 people would have it. And as person ages, it shows the prevalence or the increased risk that an individual will have to developing a condition that will cause dementia. This slide also does a good job of showing the disparities between race and ethnicity in terms of the increased risk for someone who's Native American, Alaskan, or African American to the late onset Alzheimer's disease. Nice slide, very nice visual, but it also should reflect to you that many people go to their deathbed with no dementia. And so dementia is not a normal part of aging. What are the other conditions besides Alzheimer's disease that cause dementia? This is a nice little visual of them. I want to point out that the frontal temporal dementias tend to be younger onset. Those are conditions or diseases that we see happen before the age of 60, usually between 30 and 60 we see them happen. This visual also helps us understand that the biggest culprit of dementia is Alzheimer's disease. I do think it's also important to note that if someone has a dementia, it's probably Alzheimer's, or it's probably Alzheimer's and something else. So if you have one condition that causes the dementia, it's not that you're not immune from getting a second. And so this is a nice layout of the different types of dementia. So we saw a slide, just the last slide, talking about the prevalence of dementia for the general population. Now let's take a look at someone who's living with an intellectual disability. For someone who has an intellectual disability and does not have Down syndrome, we see the prevalence if you're 59 years or older. For dementia alone, it'd be 13.1, but for Alzheimer's, it'd be 8.6% chance that you have that disease. We see when you get older at 64 and older, the rates increase. Now, when you compare someone living with an intellectual disability and it's non-Down syndrome to someone who has Down syndrome, you can see the rates really increase. The rates are huge bands. Again, we don't have as much effort and energy right now and knowledge regarding intellectual disabilities and dementia, but that's going to come with time. And so what we see here is at the age of 59, if you have Down syndrome, the range will be 30 to 75% of those folks will have Alzheimer's disease, where if it's not Down syndrome, that's the cause of the developmental disability, it's only 12%. Now, when you take comparison of someone living with Down syndrome to the general population in this age bracket, you see the general population, it's only 0.4% of those individuals will actually have Alzheimer's disease. So a big discrepancy. And so what this really means is that individuals with Down syndrome have a higher risk, it looks like, to get Alzheimer's disease than the general population. Why is that the question? Well, let's look at actually the disease process to answer that. So Alzheimer's disease, or the pathology that occurs in the brain, there are multiple things that happen. The first is that there are these chemicals between the neurons that help the neurons function and communicate. When the disease occurs, these chemicals start to disappear. The cognitive enhancers, the Reminol, Exelon, and Aricept, what their job is to help keep these chemicals in place so they're more effective when you enter the medication earlier in the disease. The second thing that happens is this protein that's naturally in the brain that needs to be in the brain. It has its function, but it's supposed to leave and go out through the spinal fluid, but it doesn't. And so what happens is it hangs in the brain and it creates these plaques. And so it's called beta amyloid plaques. And they for the neurons that are in your brain that are supposed to be doing all the thinking and your brain does, are cognitive abilities. And the third process is tangles. These are tau tangles that occur in the brain. Again, Tau is another protein that's in the brain naturally, has a purpose, but it goes awry during the process that when the Alzheimer's disease gets impacted. And the fourth issue is that we see that there's just an atrophy or shrinkage of the brain, that we lose neurons. So these four processes are what we call the pathology of Alzheimer's disease. And this pathology, when it accumulates enough, it can then show up and impact a person's function. So when we look at the pathology and we look at someone living with Down syndrome, what we find out is that a person living with Down syndrome has been born with a full or a partial copy of chromosome 21. That chromosome carries the APP gene, and that APP gene produces that protein, amyloid precursor protein, APP, or amyloid protein for short. So someone with Down syndrome, they have the gene that's producing this protein, and so they tend to produce more of this amyloid protein, which leads to those beta amyloid plaques developing. And they also, by the age of 40, we see folks living with Down syndrome having plaques and tangles, also the tau tangles. So because they have this extra copy, full or partial of 21, they have the mechanics to create the pathology in their brain. And so that's why folks living with Down syndrome are at much more risk of Alzheimer's disease. So diagnosing Alzheimer's disease, that's something I've done for decades now in terms of my focus as a professional, working in a clinic for over a decade and now working with 40 clinics throughout the state and trying to help develop additional ones. The areas that are red on the map are places that we have affiliates. These are clinics that actually do the differential diagnostic workups for someone who's experiencing behavioral and cognitive changing. And we asked many of them, how do you do, or do you have the capacity to change your evaluation protocols to accommodate someone that has an intellectual disability? And of those 40, only 7 said that they did have the capacity to change their protocols to accommodate someone. Why is that? Why can't the standard protocols work for someone who's living with an intellectual disability and experiencing additional cognitive declines? Well, here is the reason for that, or the reasons. First of all, the premorbid cognitive abilities, the person's cognitive abilities is less than what can be measured on most of the standardized tests. They come to the standardized tests with not being able to do them to begin with. They've not been normed for them. This is the biggest reason there are so many challenges. The standardized tools have not been designed for them. They also have a much different level in terms of functional skills or daily skills, and we're going to go through these two shortly. The third reason is often medical problems can mimic dementia and they're mistaken for Alzheimer's disease or missed. And then there is a tendency for dementia to be expressed differently with someone living with an intellectual disability versus the general population. So what does it take to get diagnosed with dementia? Well, 2 of the biggest players in the industry, the National Institute on Aging and the Alzheimer's Association, have established a diagnostic criteria. In order to be diagnosed with dementia, you have to meet this criteria. You have to have cognitive or behavioral changes that interfere with your function. It has to be a decline from a previous level of function. It cannot be explained by delirium or psychiatric disorder. And the detection of those declines are figured out through this history and this objective cognitive assessment, or that evaluation protocol I keep referencing. And at least 2 cognitive domains in the brain have to be impacted. Most people, when they think of the brain, they only think of the memory and aren't really in tune to that. The brain has actually multiple domains that it's responsible for. So in a nutshell, to be diagnosed with dementia, you have to have a measurable decline in your function or activities of daily living, and it has to be a decline from a previous level. You have to have a measurable decline in your cognitive abilities, and it has to be a decline from a previous higher level. And the decline, the behavior and cognitive changes cannot be due to a medical or psychiatric reason. And all evaluations for cognitive and behavior change should always start with ruling out the medical and psychiatric aspects that could potentially cause that cognitive change. Always start there. So I keep talking about function. What is function? The next two slides are going to explain that. This is the ADLs, and we're going to talk about the IADLs. The ADLs are the activities of daily living. These are things we learn in infancy, toddler, and young in our childhood. How to dress ourselves, how to eat, how to toilet, how to transfer, how to walk. So what happens is when you go in for an evaluation, they try to find out if you've had any changes that have occurred in these areas. And so an example would be someone who presents after having a stroke. And they're now post-treatment, but they're no longer able to dress themselves, but they could dress themselves prior to stroke. That would be a decline in this area, in one of these areas of function. For someone who's living with an intellectual disabilities, many folks will come with less skills in these areas already, and it's harder to tease out. So for a change that might occur for someone who's living with an intellectual disability is, say, that they're able to dress themselves, but it's only if you lay out their clothes and they see the clothes and then they're able to put them on. A subtle change may be that they no longer realize they put the underwear on before the pants, so they're putting them on after, or they don't realize that the sock goes on before the shoe, or that they put the shoes on before they put their pants on. That they have a sequencing issue would be an example of a decline for someone maybe with an intellectual disability that already needs assistance. When we look at IADLs, or instrumental activities of daily living, these are tasks that we learn a little bit later and tend to be more complex. And think through the folks that you know that are living with an intellectual disability, how many of them have the capacity to do all this? How many of them are driving a car, managing a checkbook and their finances, making meals? For many folks living with intellectual disability, this is not something that there are areas that they're not able to do. So the realm of their abilities within IADLs are limited. And so again, you have to be able to ascertain that they've had a decline in one of these functions. An individual coming in from the general population, we would hear, well, they're getting lost while they're driving. They're not being able to manage their checkbook. So capturing the changes again with someone living with an intellectual disability, you have to be very observant to see where there are some subtle changes, and there's less to look at to begin with. And that again is one of the challenges of doing the diagnosis. When we look at those cognitive domains, here are the 6 ones that the DSM-5 indicates. And so when someone comes in for an evaluation, we have standardized tests that have norms that can measure these different domains for an individual. And I keep talking about these norms and standardized tests. And I think one way to understand them is to look at cholesterol. I think most of us have gone into our doctor, they take blood, they measure, they look at your blood, and then they determine how much cholesterol, LDL, HDL you have. And then they take your results and they compare it. Are you a man or are you a woman? Are you over 19 or under 19? And then based upon those criteria, they say, well, you know, your results are desirable, or they're borderline, or they're high risk. And then they do an intervention. If you're in the high risk category or borderline, they kind of work with you to try to get them down. So we have these kind of norms, which have been set up based upon large research projects. Thousands and thousands of people have participated, so that if they take your results and they plug it into a category, they're really confident that that is an appropriate category for you to be in. These norms are set up for many functions of our body, including blood pressure, weight, our heart rate. These type of norms have also been developed for those cognitive domains. So we have norms and tests that measure your cognitive domains abilities, and then they have been put into categories to let us know whether or not you're performing well. And again, to be diagnosed with dementia, you have to have a decline in your cognitive ability. So what they do is they have what they call standardized tests. Now this is SLUMS. It's a very general, global, basic screener. In most clinics, you would use this to actually give you an idea which other tests you're going to pull out. It just gives you kind of a starting place. In the clinic I worked at, we used the mini mental to help us with our group. And what all these screeners and tests have, they're set up also through large studies. If you come in and you do this test, did you have a high school education or less than a high school education? What is your age? And so the tests have been set up to kind of level set. So say you are 70 years old, you grew up on a farm, you actually didn't go through any type of education, you farmed all your life and now you're retired. We wouldn't think your results would be the same as we saw somebody who's in their 40s, who's a physician and also has a master's degree in language arts. We would expect them to perform differently than you because what we're trying to measure in these standardized tests is that decline. So we have to know where we think you started and if there's been a change, if you've come down from that. And so all the tests are set up that way. And with the tests, there are tests that are a point that many folks with an intellectual disability would not be able to do the entire screener or test. So here's an example of the first question. You have $100, you go to the store, you buy a dozen apples for $3 and a tricycle for $20. How much did you spend? How much did you have left? The next set of questions, I'm going to give you a series of numbers. I would like you to give them back to me backwards. So if I say 42, you should say 24. And then so they give them a series of numbers wanting them to repeat them backwards. The last question has a small story that they have a lot of details in, and then they ask you questions about. When again, you think of someone living with an intellectual disability, this is a basic screener. Many of them would not be able to do this entire form, so they would not be able to get a score to do the measurement. So this is where the rubber meets the road, is that the tests that we've set up in our protocols, folks living with intellectual disability cannot do them and they're not set up for them. And so it's hard to figure out there's been a cognitive decline. And then we have that functional piece. You have to be able to capture that there's been a change in that person's function. So what we need to do if we're interfacing or we know or we're working with someone that has an intellectual disability, we have to help them figure out what their personal baseline is or what their norm is. And one way to do that is by using this early detection screen for dementia, the NTG-EDSD. It helps to capture information and establish that norm. The other thing that should be done is that records regarding the whole person should be kept. Their social, vocational, legal. What you're trying to do is capture a record about all their abilities and their skill sets. And then the other part I always advocate is using technology, especially if you have someone who has limited verbal skills or reading skills. Audio taping is a really good way to do that. And let me give you an example. So you have someone who's able to make their lunch and they always make themselves peanut butter and jelly. What you would do is you would videotape them making that peanut butter and jelly sandwich. You tuck the videotape away and later on, if you notice some changes, you would compare how they are doing that task to when you videotape them. And watching that, you may find out now that it used to take them 4 minutes to make that sandwich and now it takes them 40. Or they no longer know how to take the lids off the jars or how to put the sandwich together. So you look for those qualitative differences, those subtle differences to capture some of the changes. This is really an important aspect and you really should think outside the box and look at ways to do this. One standardized text actually that we have that talks about a little bit about the visual is the clock draw. So the clock draw is where you have a person draw a circle, they put in the numbers in the clock, and then you ask them to put the hands at the time. So the clock draw has been studied, and what they do is they score it based upon if the person is able to put the numbers in correctly, they put the time in correctly, the spacing. So there's different ways that they score this. But what we find is that as someone, particularly with Alzheimer's disease, goes through the process, their ability to draw the clock becomes impaired, especially because the visual spatial and the sequencing and the distancing, all those pieces start to get involved in the disease. When we did clinic, we would have patients do this every year, and you would see changes in that clock. And so even the clock draw or something the person can do is going to be really helpful. One of the times that where I finally was convinced about the clock draw was years and years ago. I would do screenings in the community, and I had a gentleman that presented to me. He was retired, and he said he was coming in for the screening because his wife said something was different. He wasn't himself. And so I did the mini mental, which is what our clinic did for that basic screen. And he got a 29 out of 30, which is a normal score. And then I had him draw the clock. Well, he drew the circle, and then he drew the numbers outside the circle at the top quadrant, all up at the right-hand side, and then put the hands for the clock on the other side of the line on the bottom left. Now that's abnormal. That's not a normal clock. And so I asked him, what did he do for a living? And he said that he had been a mechanical engineer. A mechanical engineer should have been able to draw a clock. What had happened is, because that was a big red flag, it was a unique thing. He got 29 out of 30, but on the mini mental, for those of you who know it, there's a copy draw in there. He had missed that point. He also could not draw that clock. So we referred him into clinic, and he actually had a vascular dementia, a part of the brain that affected his visual spatial and his organizational skills for the drawing. So being creative and looking at ways to capture that person's skill set is going to be really important going forth, because we know that the standard protocols are not going to help too much when the person starts experiencing declines. So I've talked about this EDSD, or the Early Detection Screen for Dementia. It was designed by the National Task Group, or why they call them NTG. It's an administrative screen. It is not a standardized test. It does not have norms. It's not considered an assessment. It was developed after the DSQID, and it's meant to help with capture abilities for someone who's living with an intellectual disability, plus to try to capture some of the changes that might be going on for that person. It helps to establish the person's baseline or their norm. And so the group recommends that you do this tool at the age of 40 for someone who's living with Down syndrome, other folks living with an intellectual disability that's not Down syndrome when they suspect changes, and then do it annually after that. There's another group out there that believes you should screen everybody at the age of 35, and then only annually after any concerns arise. So you would do it and you put it away, and if something changes, then you'd bring it back out and do another one. I'm actually thinking differently about this. I think that that tool should be done at the time someone leaves the school system, and goes into adulthood. And the reason I'm of that mindset is that when someone's in the formal academic setting, they interface with professionals that have the capacity to capture a lot of information about that individual succinctly, like speech and language therapists, occupational teachers. We also know that the school system for them is usually a highly structured and rich environment, so they tend to be able to function at their highest capacity when they're in that type of a setting. And what I have seen too, when I worked at one organization, is that we'll see people come out of the school setting and then they go into a very relaxed, non-structured time frame and aren't doing a whole lot. We saw them lose skills. And so you wouldn't be able to capture their highest ability if you waited till that point. The third reason is there's a higher prevalence of seizure disorders and ambulatory issues for folks living with intellectual disabilities. So I would hate to have someone have a fall and sustain a head injury in their 20s and you haven't captured the EDSD. So I always, again, advocate you do it at the time of transition from secondary schools to post. You tuck it away till the later time, wherever the person reaches 35 or the 40, depending whose recommendations you're going to follow. The EDSD is very simple to complete. It'll take anywhere from 15 minutes to 60. The initial one takes more time. After you start doing them and become very familiar, you become very efficient. Doing them, there are 4 primary sections to them. They should be done by someone who knows the person really well, at least 6 months. By having staff and yourself do them, you become better at being an observer. And the EDSD is really a record that captures health and function information that will be really critical if there are changes. I'm going to go through the form and the manual rather quickly here, but I do want to point out the manual has an Appendix A and Appendix B. The A is the instructions, which we'll see as we go through the screen. The B is that important piece that if there is a change, there should be labs and medical tests, the ability to rule out any medical issue before you actually dive into there's an issue with like cognition, like Alzheimer's disease. The tool does come in many languages. Here's the front page of it. This is the form. Here's the instruction. It's Appendix A, page 13 in the manual. It's the how to complete the form. So here's page 1. And here's the instructions on how to do it. You're welcome to write as much detail as you want on this. And if there are things that don't quite fit, just put them on there. Page 2 looks at health. Page 3, now we're starting to talk about that function or the activities of daily living. On this page, you'll notice that the top columns have changed in heading, and they're now starting to try to capture changes. So what you'll see is that does not apply. So needs help dressing. The person can dress themselves, so you would put a check in this box. Always been the case. Or like in the case that they need help dressing, yes, they need help dressing, but that's always been the case. Always but worse. So they need help dressing, but they even need more cueing or more physical assistance. New symptoms. In the past, they were able to dress, but now they can't dress themselves. When you put a check in the always but worse or new symptoms in the past, that is a flag for you to do further investigation. This is an attempt to capture a change. It could be real subtle, but it's an attempt to capture there's something different and it's worth further exploring. And then we are focusing on memory and behavior. Again, look at the top, the categories and attempt to see if there's been a change. On page 5, we're now looking at chronic health conditions, and then the category headings have changed. Condition not present, say heart condition, never had a heart condition, doesn't have heart condition problems. Or they've had a heart condition, but it's been lifelong. Condition diagnosed in the last 5 years. In the last 5 years, they've actually been diagnosed with a heart condition. You would check there. Recent, in the last year, they were diagnosed. Again, the pinkish red categories are where you will be getting tipped off to try to think about, should we do some additional exploration about this category? Page 6 is the final page. They work as capturing medications and any next steps. Simple form to fill out, but it's a running record of, as you see, capturing as much medical history and functional, behavioral, and memory. So I've said a couple times now, it's really important to work on the medical issues, rule out medical problems before you dive into additional cognitive workup. And this visual will help you understand that. So on the National Down Syndrome Society's webpage, they talk about, or in this document, they talk about the prevalence. And so their categories that if someone is in their 50s and living with Down syndrome, 30% of them will have dementia due to Alzheimer's disease. 70% will not. When someone reaches in their 60s, it's 50-50. 50% chance that the person is living with dementia due to Alzheimer's disease. I'm putting this up there because what has happened is people now realize that folks living with Down syndrome have a higher risk for Alzheimer's. However, there's this natural inclination to jump to the conclusion that if there's any change at all, it's due to Alzheimer's disease, nothing else. And so we did a recent training, a half-day training, and Dr. Pritchett, who's a psychologist at Gunderson and La Crosse, was a part of our training team. And he talked about a young woman that, or not a young woman, a woman, I think she was in her 40s or 50s. I'm not sure how old, I think she was in her 50s, who came for her evaluation. She had Down syndrome. And the reason for the referral is that she was declining to walk anymore. She would only sit, and she was nonverbal. And so she would no longer walk. She wasn't participating in the activities she had been. She was withdrawn and had no initiation. She pretty much has checked out. And so they thought she had developed Alzheimer's disease, and so referred her in to be evaluated for that. When he looked at the record, he realized that she had not been worked up medically, and so asked that she go have a medical evaluation. Well, the medical evaluation came back that she actually had a hip fracture. And the reason she wasn't walking is that she was in a lot of pain, and she wasn't participating because she was in a lot of pain. And so ultimately they addressed the hip issue, and then she came in for an evaluation, and she didn't have Alzheimer's disease. What she had was a medical condition, but she was not able to verbalize the pain she was in or where the pain was. People had jumped to the conclusion. So I want this visual to stick with you, that you have to do the medical. It's not an automatic just because someone's living with Down syndrome and they've had a change. It's because of Alzheimer's disease. We would see people coming in with a urinary tract infection, and they thought it was Alzheimer's disease. You clear the urinary tract infection and no issues. So what are the warning signs to look out if you have someone that has an intellectual developmental disability? Well, unexpected memory problems, getting lost, misdirected, problems with gait or walking, a big one, seizures. Onset of new seizures later in life is a big red flag. Confusion with familiar situation, changes in personality, and these are all the ones that the EDSD folks have put in their manual. In addition, these are other ones I would encourage you to look for. Language changes, having problems finding words, being repetitive, a shrinkage of their vocabulary, changes in the quality and the fluidity of their speech, and again in function. Has there been changes? Have they historically been able to take a bath, but now when they get in, they can't figure out how to adjust the water temperature? Have they not been able to figure out how to put the toothpaste on the toothbrush? Subtle changes that you may see that you start to pick up with, and you say, that's different. Behavioral pattern and routine changes. One of the best examples I have is someone that we had come in that had been, after their day was done at their center, their day programming, they would always go out the exact same route out of the building and then catch their transportation. Well, all of a sudden, they started going different routes and getting lost, and transportation would come in and look for them. So it was a change in the behavior, and that individual unfortunately did actually have Alzheimer's disease. But it was that subtle change that was picked up that caught, and so it can be really subtle. Something to keep in mind, there are things that can cause problem or mimic issues that may suggest dementia. So folks living with Down syndrome particularly will have some sensorial issues that are higher risk. They're at higher risk for cataract and other vision issues, plus some hearing loss. And so what we'll see sometimes is family will say they have short-term memory. I told them this stuff, but they didn't follow through. Well, it turns out they actually never heard them, so they didn't do it because they didn't hear what they were told to do. They didn't catch it. And so always, again, looking at the medical or the sensory issues first before thinking it's Alzheimer's disease or another dementia is really critical. So to strategize to build and maintain a baseline, you need to define the norms for the person. EDSD is a wonderful tool. You can have multiple people complete it. If you have someone who has like an employment or a day program, you could have those folks fill it out. You could have family fill it out. they're working with professionals, case managers, they can fill it out. So you get multiple viewpoints. And again, you kind of compare, tuck away, and store. Maintain records on the whole person. Use simple tracking tools as like a notebook and a calendar. I know when I did case management for folks that were diagnosed in our clinic, and then I followed up afterwards after the diagnosis. Simple things like use a calendar, write a little note if something changed or different, and then you don't have to go, oh, was that in May or was that in April that happened? And just keep little notes on the calendar and then keep all the calendars together. Use technology. I think I've explained that. Be creative. A lot of cool things. I think COVID has introduced us all to more technology. Be organized. Invest up front with getting a succinct system for that individual. You need to capture their norm, their baseline. If you notice changes, contact the primary care physician. Be aware and be able to kind of give them the details, the what, when, context, how long. Appreciate that interfacing with healthcare providers and the structure they work in. They are set up for 10 to 20-minute visits. If you come in and have an hour's worth of conversation to give them, it's probably not going to go well. You have to come in kind of organized and think about the whole concept of elevator speech and really listen to the question so that you answer the question that you give them the answer that they need to hear. The other thing is what we found out when we did the training on the EDSD is even with the 40 clinics that I interface with, none of them had seen the document. Very few healthcare professionals have seen this document. So if you take it into your doctor, ask them to put it in the medical record, you might have to do a little education for them. But most healthcare providers are used to looking at documents, and once they get trained on it, they know how to quickly scan them and look for pieces of information they're going to need. So you need to educate them and get them acclimated to it. And of course, if you know changes, you should always be expecting for them to start with ruling out any medical or psychiatric issues before jumping to the conclusion that it's Alzheimer's disease or another condition that's causing the dementia. Now this last slide for me, I use it all the time because it reminds me we all deserve the opportunity to live our best life. And unfortunately, folks living with an intellectual disability are kind of at a disadvantage if they start to experience additional cognitive changing because the healthcare world just doesn't have the toolkit for them. And so we need to be good advocates and helpful and set up the ability to capture their baseline or their norms ahead of time so that if they change or have a change that we can figure it out so we can intervene and let them continue to live their best life. These are the resources I used to put this together today. And then I did want to thank Anne from Brown County ADRC and Kate from the Alzheimer's Association, Laura from UW Green Bay for the invitation. I hope you found this helpful. I don't know if there are questions.
So yeah, let's open it up for questions. If you have a question, you're welcome to use the chat feature, or you can unmute yourself. So it looks like everybody's on their computer. So if you'd like to unmute yourself, there should be a little microphone button. I will share, and I did put this in the chat, but in case you didn't check that, Jody has given us PDF copies of the EDSD. So I will email those out afterwards, including the manual. So you will have access to that information. But if anyone has any questions, we will open it up for that right now.
Anybody else have any tips or ideas to share?
I have a question, Jody. Sorry, this is Anne from the ADRC.
Yes.
I know that there's lots of research out there on how to kind of respond to the more difficult behavioral symptoms that people with Alzheimer's might experience. Do you have any insight or tips for people dealing with behavioral symptoms in people with IDD and dementia? Are the approaches different or anything like that?
Personally, I think they're very much similar in that typically in the general population, often like UW, we recommend like the DICE program or the DICE kind of protocol. It's the same thing. It's gathering information, but it tends to be best when you have someone who knows someone and being succinct and looking at that. So it would be pretty much the same would you do with the general population. There's no magic bullet. It actually is being a really good observer and kind of putting the pieces together. And like I said, like this person getting lost, transportation saying they're not coming in, that was a real subtle thing to pick up on. But people would have tagged that as a behavioral issue. Here it was their change in their capacity to actually get out and they needed to do an intervention. So it really wasn't a behavior problem for the individual. They just needed more assistance. And it can be real subtle. And same like with the dressing or like not wanting to shower. Well, the person didn't know how to adjust the temperature. And so the water was scalding or cold. Again, to kind of, there needs to be an investigation or some insight and an appreciation. It can be just something really subtle that makes a difference. But that person too is, oh, he's behavioral, he's refusing to bathe. Well, he's refusing to bathe because the water's cold and he doesn't know how to adjust it.
Thank you.
I just had one quick comment, Jody. I really like that you recommend doing the EDSD earlier on, like in, you know, when they're transition from high school into a program, adult program, because of what you had mentioned, like they could develop a seizure disorder and other things. Oftentimes people wait until they start noticing, gosh, something's going on, and then they're going to do it, and then we lose that opportunity to have the baseline. So I'm glad that you mentioned that.
Yeah, and one of the other things is I was working on a project for a large nonprofit, and we did some research in other states, and some other states that didn't have family care or IRIS in place. What they found is that their kids were exiting the schools and just going home, and there was no programming or no structure. We saw one video after another of families saying, they no longer can do this, they no longer can do this, because they didn't have an enriched structure or ability, a desire to get up for that day. And so they lost skills. And so it just becomes really good to capture it whenever you think they've had the best chance to get it. I've been alone on that drum, by the way. I've not convinced too many people of it yet.
Well, the next question in the chat box might be a good one, because it says, what sort of community action can be taken?
What sort of community action?
Yep, community action.
I do think groups like what you're doing is really helpful. I've also found that many of the folks in family care, the case manager, especially in some like in the Milwaukee County area, we see them very proactive in this arena in terms of capturing that and being more aggressive with the physicians trying to work it up. But I do think we all need to do our part, and having a session like this and speaking up and advocating, taking those documents to doctors and say, I want this in my medical record. I think those are all real helpful, but I think it changes when we network and we work together. Yeah, I think that's where it's at, because unfortunately the population is smaller, and so they don't get like the research time and all those pieces. So any way we can make a difference. I know the board for people with developmental disabilities, they've worked really hard on this too. The other organization I think that has some capacity and help is the Special Olympics. I find that they've been very organized, but again, some of this stuff happens later in the lifespan, so the person might not be participating in those pieces. Anybody else have any other thoughts? That's just what comes to my mind.
It looks like someone asked, how can we spread the information to group residences?
So, and when they say group residence, are you talking about family, what kind of housing?
So I don't know if Susan, if you'd be willing to unmute and ask your question a little more detailed for Jody, or put it in chat box.
Sure, I'd be glad to do that. I'm actually here in Minnesota, and we have a number of group home residents, and also we have a structure where a lot of them attend work or day programs. And it seems like I don't think we've ever, in a care conference, ever reviewed that information. So I don't think that information is out in the community.
I would totally agree with you. I totally agree with you. And one of the things, I ran a very large day center. We had like 60 people a day come to our center in this inner city of Milwaukee. And many of them were on family care, which is our support, where they case manage the individual. What I found is the day center, we did an evaluation on the patient or the client every 6 months. The family care people did one every 6 months, and the group home did everyone every 6 months, but none of them synced together. And then people wouldn't participate in each other because it just seemed so much like work. But I think it really is hopefully people would advocate, let's get all on the same page and do them together and share. And so we tried really hard, but it became very difficult. And depending upon the regulation, like the housing, they may have rules that they have to follow, and they figure this is all we can handle. We're not going to do anything additional. But until they realize how helpful this tool can be, this EDSD, I think it falls short. It's again, all of us advocating, providing trainings. I'm happy to provide trainings if I can. You just have to go through our Badger Care. So if you have group homes and you can get them together, I'd be happy to do what I did today here if that's of help. But you just have to work harder on this. I find in Wisconsin, though, the care management organizations, they have actually implemented the EDSD into their assessment piece. So they've like Inclusa, Milwaukee County, or Family Care in Milwaukee County. Many of them have included this in there. We've done trainings with them and it's a part of them. I think it's a little different when you go into people that are in IRIS. I'm not sure how much the ICAs are doing with it, but by all means, we could work with that.
I know it's something we talked about as a committee, and that was part of why we offered continuing education today, to try to help one, get the education out there and help the assisted living, that any of those taking care of people developmentally disabled, to get some of the continuing ed that they needed. So maybe some of you are here today because of that. So hopefully that helps get the word out too.
Well, we also found when people actually did the document and send it to their doctor, like some of the housing in Wisconsin, the doctor goes, what is this? You know, what am I supposed to do with this? And so that's where, you know, we've explored potentially doing another project trying to help educate healthcare providers to understand the tool. Because to be honest, if you have someone, it's hard. It's really piecing together the protocols are limited in terms of working someone up, which is unfortunate, but we can change that. That's up to us, right? We can change that. I truly mean that everybody should have the opportunity to live their best life and have chances of getting the help they need so that they continue. And unfortunately, there are some people that need us to help make that happen.
Kate just put in the chat box, and I had put it earlier. We have an evaluation form.
Oh.
And we also, not just to give more feedback for us on if this is a helpful presentation and what other presentations you might want to see. And then also an opportunity for you to put your email and phone number and name how you would like it on a certificate if you would like credit for attending. But we have a few more moments. If anyone, we want to make sure everybody had a chance to ask their questions.
All right, well, thank you so much to everybody. You will be receiving the recording as well as the files that I mentioned, and I'll include a link to the survey as well if you just don't have time to take it right now, or you need the certificate but just don't have time right now. That will all be coming out in an email for those of you who registered or sent me your email. Thank you so much to Jody. I learned so much. I'm sure everyone else on this call did. As always, you did a wonderful job with your presentation.
Oh, thank
so
you.
we cannot say thank you enough for that. If anyone has any questions, you should have my email if you registered, as I sent out the reminder this morning. I'd be happy to help answer, and if I can't answer, I will certainly get you to the person who can. So thank you for your time and have a wonderful weekend.
Bye-bye.
Goodbye, everyone.